Disclaimer, welcome to Triage RN. This podcast is for general education, entertainment, and discussion purposes only. All patients and scenarios are fictional, hypothetical, and generated using artificial intelligence. No real patient information is used. This podcast is not medical, nursing, clinical, legal, regulatory, employment, or personal advice, and it does not establish a standard of care or create a professional relationship. Do not use this content to diagnose, treat, triage, or make clinical, legal, or personal decisions. Always follow your local laws, professional standards, employee policies, and current clinical guidelines. Consult your own healthcare provider, lawyer, licensing body, employer, or professional liability insurer when appropriate. In an emergency, contact your local emergency services. Welcome. This is Triage RN. This is episode 3. Welcome. We are back. It's been good. It's been a minute. I pre-recorded a couple episodes to kind of get the ball rolling, kind of seeing how it felt. But now we're back. I'm trying to pre-record like maybe two every session. Just to kind of get some feedback and get the ball rolling and improve things if I have to, or maybe I just don't like an episode, whatever that may be. But we're back. We're here. We just put our own episode today. I guess that would have been a week ago by the time you see this. It's weird talking in the future or the past tense. I don't know. It's really confusing me. However, we are back. Now, the feedback I'm getting is superb. I love the feedback, so I appreciate you guys. We had some really good feedback, and I think one of the biggest feedbacks I've heard was that in our triages, or in my triages here for this podcast, we need a little bit more background story to the patient, a little bit about their history, maybe their age, their comorbidities, those type of things. Now, I have to err on the side of caution, okay? Now, to get this podcast up and running, I had to go through a bunch of hoops. I had to talk to my licensing board because I'm still a practicing nurse. I had to talk to my employer. I had to talk to my union. I had to talk to a whole slew of people who then I officially got directed to a lawyer who represents nurses countrywide. So I had to talk to this person who then recommended what I do and don't do and the disclaimers that you see all around us here. So it wasn't just I could just get this going and say whatever I want, right? So I do apologize about certain things that I can say and can't say. So I'm trying to keep it limited on those things while still keeping it fresh, still keeping an open dialogue and still inviting people's opinions. And trying to navigate that is kind of tricky sometimes. I'm still trying to figure that out, right? This is only episode 3. I think once we get down the road and have a dozen of these put out, I'll have a little bit more understanding as to, you know, the flow of things and how we can navigate that system a little bit better. But for now, I kind of have to kind of bite my tongue a little bit, just because I am restricted on what I can say and can't say. Just based on those type of things. Now, that doesn't mean I can't talk about a certain topic or I can't, you know, give you all the information, but I need to keep certain things vague, like comorbidities to a patient. That could bounce back and someone out of the blue could be like, hey, that was me you're talking about, when really everything here is AI generated. So everything is just, I'm putting in info to an AI generator, whether that be chest pain like last week's episode or this week's episode topic, which I'm not revealing yet. But if I put that just random category into the AI generator, they're going to produce me this triage, right? So that way we don't keep it patient specific, right? So someone doesn't come back and we say, oh, this 45-year-old male with these comorbidities, with this history, who was born here or is this date of birth. Like, that's just a little bit too specific for what I can do here. But I'm learning that maybe we can give like an age range. We'll give like a range of like, oh, this person's between 40 and 50. Or maybe we can say they have these generic comorbidities, like the classic COPD, the classic hypertension, those kind of things. I can't get into specifics of like, you know, this 45-year-old male had, I don't know, an MI this year. I can't do that. I got to stay away from those kind of things. So I do apologize about that, but we're going to get into some more specific things later. We're trying to keep it broad and basic for now, but just stay with me. Stay with me. We're going to get there. I want to try to push the boundary a little bit, but I want to stay safe as well, and I want to keep this going for a long time. So just bear with me. We're trying to still figure out the flow, and we're going to get there. We're going to get there, so bear with me. Now, other feedback I have gotten was really good, actually. I really like the feedback. Everything's really positive so far. Again, if you have any things to improve upon or anything like that, please let me know. Please reach out. Beginning of every episode, I want to talk about future development or improvement or fact checks. Maybe something I said that wasn't right or that was right. I think in one of the episodes I had said that, you know, you got to goop all 10 of these electrodes when really, or all 12 of these electrodes when really you're putting on 10 electrodes instead of 12 electrodes. So like good little feedback like that can really help this go a long way and teach other people that may not be familiar, and teach me as well. That's what I'm here for too. I'm here to learn. I'm here to read the comments. I'm here for people to give me feedback. So please reach out, let me know, and we'll go from there. Now that being said, the first episode I kind of broadly talked about it, but I want to get a little bit more into like what is triage, where it kind of came from, how it originated, and what I see moving forward with our current CTAS guidelines and things like that. Because as you all may know, or if you don't know, if you're someone in triage and you're using a CTAS like system, it may be outdated. It may be outdated. It may not be relevant. It may need some changes or some tweaks. Maybe we need to relook at it. I don't know. But I think that we just need to look at a couple different things. So I'm going to go back here and just give a little bit of info about CTAS in general that I've learned just doing some research and things like that. Now, what I have learned is that, and I actually didn't know this, CTAS was actually developed in 1999. 1999. Let's think about that. That's only 26, 27 years ago. Okay. Before that, I think they were using, don't quote me, but I think they were just using like a military-based kind of system. I'm not really sure exactly what it was or anything like that, but I do know now we use kind of like these two different systems. So we have CTAS that typically Canada uses, and then we have ESI that America uses for the most part. I mean, there's a couple different regions that use different things, but America, that's kind of what we were using, those two systems basically. Now, they both systems kind of give you a breakdown as to how acute your patient is, right? So one system, actually both systems gives you a 1 through 5. So 1 being your most critical, I'm pointing the wrong way. The most critical patient right up here, as you can see, that's your immediate patient, okay? So CTAS 1 is like your, I need a physician right away. This is life or death. Maybe they are already deceased and you're trying to bring them back from a cardiac arrest or whatever that may be. Those are your CTAS 1s, okay? These are no-brainers. 1s, when they come in through the door, they're probably not coming in through the door, right? They're probably coming in with paramedics. They're probably coming in as a drop-off, or maybe you've got someone that just kind of got thrown in your department and that truck or van or whatever it is just peels away and they just drop someone off. These are typically your 1s, okay? Like, these are immediate. These are life and death situations. Now, you do get the odd one that kind of walks in or gets rolled in on a wheelchair or whatever it may be, but these are no-brainers. Again, CTAS 1s should be like quick, simple, easy to identify, right? These are the people that have blood pressure, something over nothing. Okay, these are people that have a crazy arrhythmia that is life or death. These are people that are ODing with no airway, or just no airway for any particular reason. Maybe it's obstructed. Maybe it's they're so tachypnic that now they're lethargic, right? Or maybe they're not even responding anymore. Like these are the ones are life or death. These level 1 patients are straightforward, okay? Right down to the T, you know these are level 1 patients. Now, level 2, these are your urgent patients, okay? Some examples of this may be acute chest pain, acute abdominal pain, pretty much central pain. Now, you do have some modifiers that can modify some of these things. So, like 8 out of 10 modifiers for central pain are typically a 2. That's kind of a general rule of thumb for triage, okay? Now, now, bear with me on this one because I want to get this one right because I still think this is archaic system. I think this is crazy. So, level 1... 0 minutes to physician, okay? 0 minutes. It's immediate. It is right away. Physician is on top of them immediately, okay? Level 2. I'm going to read this, okay? This is what CTAS says. Level 2. Immediate, okay? Within 15 minutes, a physician has to see this person. I'm going to pause here because when in this day and age has a level 2 ever been seen within 15 minutes by a physician? I haven't seen it for a long time. I'm going to say pre-COVID. I'm going to say pre-COVID, to be honest with you, because right now in our system, we have such long wait times that a level 2 waits hours to see a physician. Hours. Okay? Now, maybe we can mitigate that by saying you get to see a healthcare provider within 15 minutes. Maybe that's a paramedic. Maybe that's a nurse of some kind, LPN, RN, other kind of nurses that you may have that work with you. Maybe that's respiratory therapy, some kind of healthcare provider you have to see in 15 minutes. I still don't think that happens, okay? If that's happening in your place that you work, let me know. I want to know if I'm just absolutely wrong in this, but in this day and age, level 2s to be seen within 15 minutes by a healthcare provider or physician, like it was originally written to be, I think is archaic. I think that just is not possible. I don't think that ever happens anywhere that I'm aware of. Please let me know otherwise, but I think this is crazy. These are conditions that require 15 minutes to be there. So maybe it is central chest pain. Maybe it's stroke-like symptoms. Maybe it's acute shortness of breath. All those severe ones that aren't, a level 1 kind of comes down as a level 2. I'm sorry. I'm still caught up on the 15-minute thing because I think that's not realistic, okay? I think 15 minutes is crazy, and I think that part of the system in CTAS needs to be revamped. Now, if we look and try to compare, I'm going to go through them, actually. I'm going to go through them all, and then we'll compare them. So, level 3, urgent. So this is a little bit less urgent than level 2, right? So 1 immediate, 2 urgent, less urgent is kind of your level 3, but still kind of urgent. And then 4 being your more stable people. And then 5 is like, I don't really care about 5s. We'll talk about those in a little bit. But 3 is more so like I have 8 out of 10 extremity pain, okay? So maybe I fell, I hurt myself, I hurt my elbow, I hurt my shoulder, I hurt my wrist, maybe I have a foosh. All those 8 out of 10 pains will give you a higher score, right? So 8 out of 10 is your modifier that's going to give you a higher score. So if I have 8 out of 10 extremity pain rather than central pain being 8 out of 10 being a 2. Level 3s, extremity pain, that's going to be your level 3s, okay? Level 3s, do you want to guess how fast they should be seen as per CTAS? Any guesses? 30 minutes. So we went from 0 minutes to 15 minutes to 30 minutes. When on earth was the last time you saw a level 3 be seen in 30 minutes? And again, let's say it's a healthcare provider. I have not seen that happen in some time. Okay. Maybe that's someone that came and did blood work on you right away because you're level 3 and you needed some blood work for something. I still don't think that's happening in 30 minutes. Okay? We have sometimes hours upon waits, right? I just don't think that's plausible in this system currently that we have. Now, I'm going to keep moving on because there's a lot to talk about here. So I know I could talk about this for ages upon ages, but I just really want to get down the times more than anything else. So level 4, any guesses of that one? We'll pause for dramatic effect here. Level 4. So we have level 1 is 0. Level 2, we have 15 minutes. Level 3, we have 30 minutes. Level 4, 60 minutes. So they basically double every time, right? 60 minutes for level 4. So these are your more stable people. These people are waiting hours. Okay. These people are waiting hours to see physicians. I'm not talking about an hour or two. I'm talking hours. Hours. Now, it's nice to try to clean up some of these patients if a physician is free and they're in between cases or whatever it may be, or maybe they just came out of a resuscitation and they need to, pick up a few quick patients. Maybe these people have some x-rays that are already done and everything is stable and non-broken. Maybe they just sprained something. These are kind of your quicker and dirty patients for the physicians to pick up, right? I'm still saying that these people are not being seen within an hour. There's just no way. In the system that we have currently right now, I just don't see that happening. Now, let me know. It is in other places. I could be totally wrong here, okay? But I'm just saying what I see from a couple facilities that I have worked at. I have never seen this happen, okay? I've never seen a system so efficient that you see these people in 0 minutes, 15 minutes, 30 minutes, and an hour. I have never seen it, which is why I think we should almost call for a new revamp to CTask, okay? Maybe it's modifying the times. Maybe it's modifying the modifiers to fit specific time frames within these criteria. Maybe it's changing it completely so that we have a whole new system in place that fits our current healthcare system today. I don't know what the answer is. You let me know. Do you think that our current system works for CTAS in general? Do you think CTAS should be revamped? I just don't know, because I think our system's a little archaic to be able to wait 0 minutes for level 1, 15 minutes of level 2, 30 minutes of level 3, an hour of level 4. I just don't think that's possible in the current system that we have for CTAS. So let me know what you think. Give me some ideas too, right? I'll throw out some ideas to people just to be like, hey, maybe we should try this. Maybe we should try that. I don't know. It is a national standard system that was regulated by physicians in 1999. I don't know. Does it need to change? I don't know. Maybe it does. Now, one other thing I wanted to talk about briefly was the United States uses something a little bit different in most places. Don't quote me on this. I'm not too familiar with it. I've only kind of went over a little bit of research on it. But it's your ESI system, okay? So ESI kind of breaks things down a little bit better than the Canadian triage system, CTask. So, again, bear with me. I'm not too familiar with this system, but I just wanted to compare two different systems based on how CTask works versus another system, just to see what you guys think. Is it something that we maybe need to move away from? Maybe CTask is something that's so old that we just need to move to a different system in. But doing my research, I don't know. I just don't know if there's actually a system that works currently, right? So ESI kind of works the same way, right? So you have levels 1 through 5. 1 through 5 basically says how acute your patient is, just like CTask. 1 being the most immediate, 5 being the lesser of. And let's remember, there is a level 5 for CTask as well. Level 5s are basically like your prescription refills, your doctor's notes, like sign some paperwork, here you go, there's nothing wrong with this person, right? We typically don't give, I typically don't give out a lot of 5s, to be honest with you, and I always err on the side of caution about giving out 5s because I feel like those have the biggest discrepancies because they're coming to the hospital for a reason. Like maybe they just want to sign some paperwork. Sure, I'll give them a 5, but I think there's other reasons to that. So just be cautious about that. But with this other system, ESI rather than CTAS, you basically have immediate life-saving interventions, which would be number 1, right? Now their system, how it basically differs on what resources you need to help this patient. So based on the amount of resources, that's how you're going to get a higher score. The time to those resources are not stated, okay? It's not like you have 30 minutes to go see someone that requires 2 or more resources. It does not say, if you need a full hands-on deck from surgeons and anesthesia and all of those things, because you're a 1, it requires you to be seen right away. It doesn't say that specifically, and I'm going to put that in air quotes specifically because nothing I could find would really relate to wait times, okay? Now, CTASC, on the other hand, does relate to wait times, and they say 1 is urgent, 0 minutes, 2, as we said, 15 minutes, 3, 30, 4, an hour, and 5, so they can wait. Should we, and I bring this up for discussion, right? I bring this up for discussion because my question is more so, should we just get rid of wait times, right? And that's why I brought this up, is like, should CTAS just get rid of wait times because they're just not achievable? It's not, if you're following CTAS to a T, it is impossible for those 3s to be seen in 30 minutes. It's impossible. It's the system that we have does not allow us to do that, right? So do we change the system to fit CTAS? Do we change CTAS to fit the system? Do we change CTAS altogether and go to ESI? Do we take ESI and make it CTAS, and CTAS we get rid of the wait times? I just don't know what the right answer is, and that's why I'm asking you guys, right? Let me know what you think should be the CTAS, or what should be the standard for triaging, right? Should it be the CTAS? Should it be the levels that we have, that we see all around this room? Should it be a different system that they use somewhere else? Now, I'm not too familiar with what they use in other countries or specifically in other places. So let me know what you guys think. Does it work well where you were at? Does it not work well? I'm feeling like my gut feeling here is that it's just not working well anywhere based on just how sick people are nowadays, right? And the volumes of people that we're seeing and how sick they are. Like a simple 4 is not a simple 4 anymore. They have a lot of comorbidities, right? So let me know what you think. And we're gonna discuss it next time, okay? Let me know what you think. We'll discuss it next time and we'll go from there. All right, this is everyone's favorite portion. We're gonna get into a triage here. Now, remember, triage is always going to be a part of an episode, whether it's at the end, at the middle, at the beginning, maybe the whole episode. It's going to be in here in some way, shape, or form. So at the end here, we're going to do a quick little triage, and let me know what you think, because I think this is something you also see almost every day. Probably not every day, but you're probably seeing it once a week. And I'm curious how you guys deal with this in your facilities based on my experience here today. So let's get right into it. I'm going to try to provide a little bit more info this time, and we're going to kind of feel it out, see how it goes. But basically, I'm in triage. Maybe it's a slower day, knock on wood. Maybe it's a slower day. And you have this lady who is 70 to 75 years old, let's say. Okay. And I'm going to confirm here with my AI system to make sure everything's correct here during this triage. Lady is 70 to 75 years old. She comes in. She's quite distressed, to be honest with you. She is pretty short of breath. She is more so anxiety-induced as she kind of walks in. Now, she thinks she's going crazy. I'm going to be honest with you. She comes in, she's saying, I don't know what's going on. I'm seeing these bugs everywhere, and I don't know what to do. I continuously itch all the time. I can't seem to find these bugs anywhere, but I know I'm seeing bugs constantly. And she's just going she's definitely having some type of panic attack from this. Now, can I say for definite sure she's having a panic attack? No, I can't. But she's kind of freaking out a little bit, right? Maybe she comes in and she has everything taped up. Maybe she has her arms taped up. She has her legs taped up. Maybe she has like little booties on. Maybe she has a bouffant, like a little hat on of some sort, to try to protect her from these bugs. Now, she comes and sits in your chair and you try to calm her down, right? You're talking to her at a nice level, and you're trying to sympathize with her a little bit here, right? And she explains her story. Her story is the following. Recently, she moved into a new long-term care facility based on she really can't take care of herself that much anymore. Now, this is assisted living, okay? She gets some care. She gets like home care. She gets maybe some VON as well. Can't say that. Now, she gets home care. She gets nurses that comes in and kind of help sort her pills out. She gets people that come and help clean her up. Those kind of things, right? Now, she goes on and on about this new facility that she's in and how she's happy because everyone's helping her, and because it helps offset her income. Maybe she's a lower income. This is a better place for her than her last place because they subsidize financially. And overall, she's quite content with the place that she's living. They provide her food. They provide her some other services, those kind of things. Now, the trickery gets into it where she says a couple days after she moved in, she started feeling really itchy. Mostly in the mornings after sleeping. And in triage, she's actively itching. She really doesn't have a whole lot of comorbidities, to be honest with you. She is 72 years old. She does have, she did have a stroke in the past, and that's kind of why she's in more of a long-term care living situation. She's not here for that today, though. Currently, she has no symptoms of a stroke. She does say that her right hand does get a little bit weak some days, but other than that, she's mostly fine. She's more concerned about this itching that's going on all over. She's continuously itching. I'm feeling like I need to itch right now, to be honest with you. And you kind of look her up and down just to see what's going on with this itching. And you can see that she has these little kind of raised bumps on her. They're kind of red looking. And you're really trying to investigate what's going on. She thinks she's just seeing bugs, that they're not actually there. And, you know, sometimes that happens. Maybe you do have a patient that is hallucinating, you're seeing bugs. But this person, I believe this person is actually seeing bugs. And she's going bonkers, okay? Every night she says she can't sleep, she can't eat, she can't think about anything else but itching and these bugs. And my first go-to is I need to do some investigation. So I look her over very quick. Maybe I'm undoing these little tapes that she has on her wrist and her feet, right? I'm doing some investigating. And as soon as I go to remove one of these little pieces of tape on her wrist or her ankles, bugs come crawling out, okay? They come crawling out in herds. Now, if there's one thing I know about nurses, it's that we can tackle a lot of things, okay? We can tackle a hell of a lot of things, let me tell you that. Whether it is the COVID times, whether it is Ebola times. And you know what? In Emerge, I'm going to say we're probably not the best at protecting ourselves. I'll be the first to admit that. However, when it comes to BedBugs, God damn, we're putting on that Ebola outfit. Let me tell you that right now. For some reason or another, as nurses, we hate BedBugs. Okay? And we hate them. Soon as they come crawling out of her, we know these are bed bugs because we have seen them before. We are aware of them. Everyone has seen them. Everyone knows what they are. And everyone runs away immediately. Okay? Now, we're not done this triage, right? We've only assessed that now she has bugs. I haven't done her vitals yet. I haven't done anything else yet. So maybe I'm backing out of the room. I'm going to get on my PPE, my full Ebola outfit with my bouffant, my booties, my full one-piece suit. I don't know. I've seen some crazy things with bed bugs, okay? Like absolutely crazy things from nurses for bed bugs. And I'm coming back in with my suit because I still got to finish this. I got to make sure that there's nothing else going on with this person. That it's just these bed bugs, right? Now, when someone comes in with bed bugs, I need to try to rule out everything else too. So now public health in my region has kind of come out and basically said that bed bugs are not a transmittable, but they don't transmit diseases of any kind. So therefore, they're, you know, I'm going to put this in air quotes because I don't know exactly what they said, but I'm going to say, you know, a safer bug to have based on disease and spreading of disease. Okay. Now, that's not saying that these bed bugs can lead to mental health issues, to financial constraints, to housing constraints, to sleeping constraints. All these things play a factor with your health, right? So maybe those are secondary reasons, but you know, bed bugs don't spread disease, so we need to take that in consideration. Now, I don't want to take these bed bugs home. Absolutely not. No one wants bed bugs. So I feel for this gal, okay? She's 70 years old. She's having a hard time taking care of herself, okay? Let alone having to take care of these bugs every day as well. So like home care, I've heard of even like home care coming in to refuse to come help someone out because of bed bugs. I think that's a little crazy, to be honest with you, because I can come with extra change of clothing. I can come with whatever that I need to. Maybe I need to do a little decontam before I get back in my vehicle and leave, or whatever it may be. I think there's ways around it, to be honest with you. I don't think we should just be saying, you're shit out of luck based on where you live, because these things are hard to get rid of, right? Like, you need to do a full decontam. You need to get someone to come in and spray. That's not going to take 2 minutes, and it's not very cheap, okay? Not everyone can do that. Not everyone can afford to do that. Not everyone can have the ability to organize something like that. Maybe you live in a long-term care facility like this lady does, and maybe they're already spraying, but they can't just get rid of it because it's in the entire building. And this is her home now. So I really feel for these people. Really, I do. I really, really feel for these people. And unfortunately, I don't know why. Maybe you guys know why. I typically see bed bugs more with like a lower income source of housing. That's not to say I don't see it other places, but majority, I'm going to say, come from more of low income housing. And they, you know, from things I've read about bed bugs, it doesn't really come from like the dirtiness or the cleanliness or anything like that. So I don't know where they kind of come from in the lower income housing. I'm not really sure. Maybe you guys can let me know. But all I know is that bed bugs, I am itching. I don't want to be near them in any way, shape, or form. So I'm going to go into my PPE. I'm going to gown up. I'm going to do all I can for this lady. And we need to decontam this lady, okay? That's my biggest thing here. I'm not leaving this lady in poor distress. I'm taking her to a decontam spot. Maybe that's a shower. Maybe that's a bath. Maybe that's a whatever you have to get these bugs off this lady and give her some type of relief. Please do it. Please do it. Don't let her suffer, okay? These are not great things to have crawling all over you. Just think about that, okay? I don't want these on me. She doesn't want these on her. Help her out, okay? So I'm going to bring her, decontam her the best I can. Maybe that's not me. Maybe that's a coworker. Maybe that's I'm telling the charge nurse to be like, we need to go decontam this person. Maybe it's a CTA that you have, or a CCA or a PSW that's going to come help and do that. Maybe it's another nurse that you're working with. Maybe that's a paramedic you're working with. Someone, maybe it could be anyone, right? Someone just needs to go decontam this person, and just be vigilant that you don't want to be spreading this across the whole hospital. So you're going to go shower them off, give them some new clothing, bag up their clothing. You're going to take their bags. You're going to double bag it, triple bag it, seal it, whatever you got to do to keep all the bugs inside. And then you're going to probably have to find a spot for this lady to sit. You're going to have to find a spot for this lady to be comfortable for the next little bit, because she probably still has to see a doctor about this itching and rashes and the raised bumps that she has. So yeah, just, you know, I know we hate bed bugs, but let's sympathize a little bit, show some empathy towards these people, because I don't want them, she doesn't want them, you don't want them. It's not her fault, okay? I know it sucks, but it's really not her fault. So from a triage perspective, we're going to put this in the little triage here that we have. So we have a 70 to 75-year-old lady who comes in with raised bumps, or we're going to call them bites, from BedBugs. She has no real symptoms other than she's super itchy. These itches are starting to cause her some pain as well, because she's just constantly itching all the time. So maybe she's saying her pain is like a 5 out of 10 right now, based on like she's getting kind of raw on her skin just from itching all the time. Her biggest concern right now is the financial and emotional constraint, based on she's seen the bugs, she can't sleep, she can't afford to get rid of them, those kind of things. So maybe we're setting them up with a discharge planner nurse to try to see if we can help mitigate this a little bit. Maybe take some cost. Maybe there's a social worker involved that can try to help her out. There's going to be a whole team involved here to try to help this lady out, so that she doesn't constantly keep coming back with the same complaint over and over again, because these bugs are, even though we clean her off, these bugs are going to be at home, right? So she has some raised bumps pretty well all over her, to be honest with her. Arms, legs, thighs, top of hands, couple on her neck even. So based on these couple things, now she has no crazy comorbidities either. Now I know people want to talk about comorbidities, but we can't get into it too much. She has a couple comorbidities, okay? She did have a stroke. When was the stroke? Actually, let me double check here. Stroke was a long time ago, years ago. She had a stroke. Again, has no deficits, just a generalized weakness on her right side, on her right hand sometimes. But other than that, basically she's a healthy, normal living female of the age of 70 to 75 years old. She has a little bit of hypertension, but really that's all she's on. She takes a cholesterol pill, maybe a thyroid pill, an antihypertensive, and that's really it, to be honest with you. Now, I'm going to treat this as my main category here is going to be skin. I'm going to put this as a skin as my number 1. Number 2, I'm going to put this as a bite. Skin bite, because there's multiple bites on her. Now, when you get into the bite category, this can be an insect bite, it can be a dog bite, it can be an animal bite, it could be a human bite. Definitely have seen those before, okay? You wouldn't imagine how many human bites you see every now and then, all right? So bear with me. Right now, she really doesn't have any symptoms aside from she is just like super itchy. She's getting a little raw. And now she's calmed down enough to be like, oh, I feel a bit better. I can relax a little bit. So we know it's just anxiety there. She has no respiratory distress as of this moment. When I did her vitals, everything was normal. So her heart rate was 72. Her blood pressure was 148 over 72. 148 over 72. Her oxygen sats were 96% on room air. Her respiratory, once she calmed down a bit, her respiratory rate was 16, 17. And her fever, her temperature was afebrile at 36.5. So all these are normal. I'm going to check off normal vitals for this one. She's not altered in any way. She knows her date. She knows her time. Her GCS is 15. That's not a problem. Even though she thought she was hallucinating these bugs originally, that's not her problem here today. So she has normal GCS right now. Like I said, she has no fever, so we'll check that off. Now, peripheral pain. She is complaining of some rawness on her arm specifically that she just keeps itching. Now, it's specifically her right arm that she keeps scratching, actually. So I am going to give her a pain scale here. I'm going to put this as acute pain. This is not a chronic pain. This is not something she lives with absolutely every day. It's only since she moved into her complex that she's been getting these bites and this raw pain too from the scratching. She said her pain was a 5 out of 10. 5 out of 10. Okay, people. Anything over 4 gives you a higher score. Remember that. So 5 out of 10. Now, this is peripheral pain. This is extremity pain, so this is not centralized pain, so your modifier is not going to be higher. It's going to be slightly higher, but not like, you're not getting into the 2 category, that's for sure. So, bites all over with raised red bumps, with a pain of 5 out of 10 based on her rawness. It's a 4, okay? I'm giving this person, she is stable, right over here. She is a stable 4. Okay. Now, these are 4s I care about a little bit more because you're going to have to do a little bit more work with them than a typical 4. Maybe 4s just typically go for an x-ray and they're done and they come back and you don't have to do much with them. I have to full decontam this person, okay? That's going to take some time. If I'm the only person in triage, I'm not doing the decontaminating myself. Remember that, because if there's a lineup of people, I can't take a full 20 minutes to decontam this person. So I may have to find some help. I'm letting the charge nurse know. I'm letting someone else know that I need some help here. Now, decontam wise, I might have to decontam this whole room. I might have to set up another triage somewhere else. I might have to find another room to do this. Maybe you already have a secondary triage. Maybe you have a waiting room that you do reassessments in. Whatever that may be, maybe you got to shut that down because they got to come fumigate, okay? Maybe they got to come fumigate the decontam room or the triage room. Whatever your protocols are, find out what they are, because I find bedbugs are spreading like wildfire sometimes in some cities. So please figure out what your decontam policies are wherever you work. This is something you're definitely going to come across. Either if you haven't yet, it will happen in the future. And my biggest tip of advice is, I know this sucks to be the triage nurse that has the bedbug person come in, but let's show a little empathy here, okay? Like, I feel bad for this lady. She's 70, 75 years old. Probably doesn't have a whole lot of family. She's in assisted living. She can't really take care of herself completely yet. She has home care that really comes in to help her out, but she's struggling clearly. She got a new place, and there's bugs everywhere. Like, let's try to make her day a little bit, okay? Let's try to help her out. Let's give her some empathy. Let's try not to, freak out when these bugs come in and start screaming and get me out of here kind of thing. It sucks. It's part of the job. Someone has to do it, unfortunately. And we're going to move on, right? We're going to throw your PPE on. You're going to get the job done. You're going to do a bug check afterwards to make sure you have no bugs on you. Maybe you're changing your scrubs up. Maybe you have an extra pair in your locker or your dressing room or wherever you are in your break room to change into. I always personally have a change of clothes just in case I need it. Maybe you're stealing some scrubs from the OR. Maybe you're figuring it out, right? But please, my biggest thing is, it sucks. I get it. We have to do it, okay? Do the best you can. Try not to make her day any worse. Try not to make their day any worse. And do the best you can. All right? And that's a wrap for episode 3. Thanks for tuning in, everyone. I appreciate it. Let me know your feedback. Give me your critique. Fact check me. We'll talk about that next week as well. Now, you're going to want to tune in for next week, okay? Next week's going to be interesting. I'm going to get AI to give me a surprise triage. I'm going to try to do the triage live. I'm not going to go into it knowing what the triage is. I'm going to allow AI to create a scenario for me, and I'm going to live do the triage as if I normally would in my job, okay? Well, we're going to do a fake triage based on the answers and based on what AI gives me for the scenario, and we're going to see where it leads me. I'm going to go into it with no preconceived notion as to what to talk about or anything like that. It's going to just be done live. In the room, and we're going to see what happens. So tune in next week. This is Triage RN. I'm Anthony. Thanks for tuning in. Over and out.
Red, yellow, green, where do you go? Time is longer than you know. Step by step through the double doors, we decide what matters more. This is Triage RN.
Podcast disclaimer. The Triage RN podcast is provided solely for general education, entertainment, and professional discussion purposes. All patients' names, personal details, medical history, symptoms, assessments, test results, treatments, outcomes, and clinical scenarios presented in this podcast are fictional, generated using artificial intelligence. All scenarios are hypothetical. No real patient record, or professional health information is knowingly used or portrayed. Any resemblance to an actual person, patient, healthcare encounter, institution, or event is entirely coincidental. The information discussed on the podcast is general in nature and may be simplified, incomplete, outdated, inaccurate, or unsuitable for a particular situation. It does not represent a complete clinical assessment, an official guideline, an institutional policy, or the application standard of care. This podcast is for discussion purposes only. It is not medical advice, nursing advice, clinical advice, legal advice, regulatory advice, employment advice, or personal advice. Nothing stated, shown, suggested, or discussed during the podcast should be relied upon or used to diagnose, assess, triage, treat, or manage any medical condition, make emergency medical, nursing, clinical, legal, regulatory, employment, or personal, replace an individual patient assessment or professional clinical judgment, determine a healthcare professional scope of practice, replace current legislation, clinical guidelines, professional standards, workplace policies, procedures, protocols, or medical directives, or establish a standard of care for any healthcare professional or organization. Listening to, viewing, downloading, commenting on, or otherwise interacting with the podcast does not create a nurse, patient, clinical, patient, healthcare provider, patient, lawyer, client, consultant, client, or other professional relationship. Listeners should independently verify all information and consult the appropriate qualified professional before acting on anything discussed. Healthcare professionals must follow the laws, professional standards, licensing agreements, scope of practice rules, clinical guidelines, employer policies, procedures, protocols, and medical directives that apply in their own jurisdiction and workplace. Questions concerning professional practice, licensing, employment, discipline, documentation, privacy, or legal liability should be directed to your own lawyer, professional licensing or regulatory body, employer, union, or professional association, and professional liability insurer as applicable. Anyone experiencing a medical emergency should immediately contact their local emergency services or attend the nearest appropriate emergency facility. Do not delay or disregard professional medical care based on anything heard or viewed on this podcast. The views and opinions expressed by hosts and guests are their own. They do not necessarily represent the views, policies, practices, or positions of any hospital, healthcare organization, employer, educational institution, licensing body, professional association, sponsor, or other affiliated organizations. References to medications, products, services, organizations, guidelines, or third-party resources are provided for discussion only and do not constitute approval, endorsement, recommendation, or sponsorship unless expressively stated. Although reasonable efforts may be made to provide reasonable and accurate information, no representation or warranty is made regarding the accuracy, completeness, reliability, usefulness, safety, or currentness of any content. To the fullest extent permitted by applicable law, the podcast creators, owners, hosts, guests, producers, sponsors, distributors, and affiliated parties disclaim responsibility and liability for any injury, harm, loss, damage, claim, cost, or consequence arising directly or indirectly from accessing, relying upon, interpreting, applying, or misusing any podcast content. Use of this podcast and its content is entirely on the listener's own risk. Nothing in this disclaimer is intended to exclude or limit any responsibility or liability that cannot legally be excluded or limited under applicable law. Do not submit, post, email, or otherwise share identifiable patient information, confidential workplace information, or personal health information with the podcast or through its associated social media accounts.